السلام عليكم أعزائي الطلبة. محاضرتنا اليوم حتكون about iron deficiency anemia. Objectives of the lecture will be to know the role of iron in hemoglobin synthesis, diet requirement, absorption, and the iron cycle inside our body. Identify the causes and the laboratory finding of iron deficiency anemia. Knows the etiology and the general features of anemia of chronic disease. As we said previously, iron deficiency is the most common cause of anemia in the world. It's characterized by the presence of hypochromic, pale, microcytic, small red blood cells in the blood, and this appearance is caused by a defect in hemoglobin synthesis caused by iron deficiency. مثل ما حكينا بالمحاضرة السابقة بالclassification of anemia, we classified anemia based on the red blood cell indices into three types. The hypochromic microcytic type of anemia that is characterized by reduction in all red blood cell indices. تكون بيها الخلايا الحمراء صغيرة في الحجم microcytic less than 80 femtoliter, and it will be pale hypochromic نسميها due to decrease in the amount of hemoglobin inside the cell. ومثل ما تتذكرون من محاضرات الفسلجة إنه iron is a very essential component of hemoglobin. مكانه راح يكون in the middle, in the center of the protoporphyrin ring, and it is the site for attachment of hemoglobin with the oxygen molecules. So when you have a defect in iron supply, this will result in reduction in the hemoglobin synthesis. So all the red blood cell indices are reduced in iron deficiency anemia as it is considered as a hypochromic microcytic anemia. In our body, iron is distributed into 6 main compartments. يعني 6 مكانات رئيسية يتوزع بها الحديد داخل جسم الإنسان. The largest compartment is hemoglobin. So تقريبا 67% من الحديد داخل جسم الإنسان هو وين؟ Present inside hemoglobin in the red blood cells. 27% is stored in the form of 2 types of proteins اللي هي الferritin and the hemosiderin. We have also myoglobin iron 3.5%, the labile iron اللي هو يكون يعني in continuous cycling and release, tissue iron as enzymes inside the tissue, and the transport iron اللي هو transferrin. صح هو كميته قليلة بس هذا جدا مهم من ناحية الكاينetics because it's responsible for transporting iron from the site of absorption or release to the sites where it is used or consumed for the production of the red blood cells inside the bone marrow. So iron is transported after being absorbed by transferrin protein. شنو شغلة الترانسفيرين؟ It will carry iron to the tissues that requires mostly iron for the synthesis of the red blood cells, which is the bone marrow. So iron is transported mainly to the bone marrow, especially to the erythroblast in the bone marrow, to be utilized for the production of new red blood cells. إذا تذكرون من محاضرات الفسلجة قلنا إنه إحنا after death of the red blood cells, iron that is released from destruction of the red blood cells will be carried by transferrin from the reticuloendothelial cells to the bone marrow to be reutilized for the production of new red blood cells. So most of the iron carried by transferrin is not coming from the intestinal absorption of iron. In fact, it's coming from the macrophages of the reticuloendothelial system that break down the red blood cells at the end of their lifespan, and only small proportion comes from the diet. So iron is very precious. It's always in the state of recycling. احنا ما نقدر نستغني عنه، دائما نسوي له recycling. The red blood cells after destruction, iron is released, carried by transferrin once again to the bone marrow for production of new red blood cells, plus the contribution of iron that's come from the intestinal absorption. As we said, the storage compartment of iron in the reticuloendothelial system in two forms اللي هي الferritin and the hemosiderin. In the diet, the amount of iron in the food differs according to the type of the food. But in general, meat, especially the liver, is a better source of iron than vegetables, eggs, or milk. Only 5 to 10% of iron in the food is absorbed. يعني قد ما تكون كمية الأيرون عالية تقريبا النسبة اللي يتم امتصاصها من عنده تكون محدودة 10%، ما تتجاوز 10%. This may be increased to 20 to 30% when there is increase in demand. يعني من تزيد الحاجة للحديد ممكن نزيد ال absorption capacity of the intestine to 20 to 30%, but not more than that. Absorption occurs through the duodenum, with certain factors that enhance the absorption and certain factors that reduce the absorption. The factors that enhance absorption include the type of iron، يعني الهيم iron اللي يكون يعني of animal origin is better absorbed than iron of non-heme origin، يعني الموجود بالvegetables يكون صعب الابزوربشن مالته، مو مثل ما الموجود عندي بالميت الريد ميت. The state of iron, the ferrous state absorbed while ferric state less absorbed. The presence of vitamin C enhance the absorption. Sugars, amino acids all enhance absorption of iron. When there is a state of increased demand, such as pregnancy or any other condition that increase demand, this will result in enhancing the absorption of iron. We have certain factors that reduce the iron absorption, which include the presence of inorganic iron, non-heme iron, the ferric state of iron, consumption of anti-acids، هذا حتقلل لنا اللي يستعملوها على معالجة الحموضة مالت المعدة، ممكن تقلل absorption of iron. Tea consumption is also will reduce the absorption of iron. Phosphates, all these can reduce absorption of iron. The amount of iron required each day to compensate for the losses from the body and for the growth varies with age and sex. شو وقت تصير عندي أعلى الحاجة إلى iron? The highest requirement occurs in pregnancy, in the period of growth, adolescence, and during menstruating in females during menstruation. So in adult male, the estimated requirement is about 0.5 to 1 milligram per day. This is also the amount of iron required in females postmenopausal, يعني after the age of 50 when they don't have any more menstrual cycle. While in females, menstruating females, the requirement of iron is doubled. It's about 1 to 2 milligram per day. Pregnancy, this will also increase the amount further to 3 milligram per day. Childhood and adolescence, period of rapid growth, the iron requirement is also increased to between 1 to 2 milligram per day. إذا نلاحظ أنه هاي pregnancy, menstruating females, childhood, adolescence، هذول نسميهم احنا vulnerable groups، لأنه هذول requirement for iron is more than the normal، يحتاجون كمية حديد أعلى من غيرهم. So any decrease in the supply of iron in the groups will result in easily development of iron deficiency anemia. What controls the iron absorption؟ شنو الميكانيزم اللي يسوي لي control على ال iron absorption؟ The absorption of storage of iron is a complex process. We have different types of proteins that are involved in this process. على سبيل المثال الفيروبروتين، dimethyltransferase 1 and the hepcidin. The amount of iron absorbed is correlated with the body demand. إذا أريد نبسطها in the simple way, when we have high requirement for iron, hepcidin is reduced. Hepcidin is a protein that is produced by the liver. إذا من يصير عندي increased demand هذا البروتين راح يقل. من يقل الهبسيدين هذا ايش راح ينتج عنا زيادة بالanother protein اللي هو ferroportin. Ferroportin that's present in the intestinal villi and the macrophages. من راح يزيد الفيروبورتين it will result in increased absorption from the GIT and the intestine and increase of iron release from the iron that is stored inside the macrophages. إذا راح يصعد لي كمية الأيرون الموجود بالبلازما. إذا hepcidin reduction will result in increase in the ferroportin, and when ferroportin is increased, this will result in increase in the amount of iron absorbed. زين أنا ليش عندي هذا strict control over the iron absorption؟ مثل ما قلنا إنه الحديد له خصوصية because the body has a limited capacity to excrete iron. عنده قابلية محدودة لإخراج الحديد من الجسم. إذا أنا زيدت كمية الابزوربشن ما راح أقدر أطلعها من الجسم. This excessive amount of iron is going to deposit in different parts of the body, in different tissues, and they cause a harmful effect over the body. كل ما يزيد عند الحديد داخل الجسم أزيد من الطبيعي راح يترسب بالتشوز، بالاندوكراين تشوز، بالاي، بالهارت، causing different clinical conditions and disease. It has a harmful effect. That's why we have to keep a strict control over iron absorption بحيث ما يزيد عندي الابsorption عن الديماند of the body. So iron in the body runs into a cycle. It enters the body through the small intestine. Then after absorption into the plasma, it will be bound to transferrin اللي هو a carrier protein. The carrier protein will carry it and deliver it where? To the bone marrow for the production of new red blood cells. It will be incorporated as hemoglobin. Hemoglobin and the red blood cells were released from the bone marrow into the circulation as mature red blood cells. Mature red blood cells will continue to circulate after a lifespan of about 120 days. Those will be effeated, destroyed, and engulfed by the macrophages of the reticuloendothelial system. الماكروفاجز الموجودة عندي بالليفر، بالسبلين، بالbone marrow. مثل ما قلنا after being destroyed, iron is released, extracted from the hemoglobin, and get back to the plasma, bound to transferrin once again to complete the cycle. يرجع مرة الثانية للبون مارو for the production of new red blood cells. وإذا أنا عندي excess of what I need, then it will be stored in the liver and in the spleen as ferritin and hemosiderin. يعني أنا أحتاجه مثل السايكل. Absorbed from the intestine, carried by transferrin, يروح للنخاع، يدخل بالسنسيتيف of red blood cells، يطلع من النخاع على شكل red blood cells وبيها هيموغلوبين، تفتر إلى أن تخلص عمرها اللي هو 120 يوم، destroyed by the macrophages in the spleen. It will release iron for the hemoglobin and get it back to the plasma, bound to transferrin، عم ترجع مرة ثانية للنخاع على مود to produce more red blood cells. وإذا عندي زيادة ما أحتاج هالكمية من الحديد, it will be stored as ferritin and hemosiderin inside the reticuloendothelial cells, liver and spleen. Now, what could potentially cause iron deficiency? Keep in mind, and this is a very important factor, إنه we have the two major important causes for iron deficiency اللي هي chronic blood loss. This is the major cause of iron deficiency in the adults. And the major two sites for the blood loss are the GIT, like bleeding peptic ulcer, esophageal varices, aspirin injection, CA of the stomach, CA of the colon. The other important site for blood loss is the uterine bleeding in females. So we have two major sites for blood loss اللي هي GIT and the genitourinary system. Chronic blood loss is the most major important factor in the causing of iron deficiency anemia. The other factor is increased demand. احنا قلنا اكو عندنا groups اللي هي pregnancy, menstruating females, childhood, adolescents. They have a higher requirement for iron. So if the iron supply during this period, it will result in iron is reduced, it will result in iron deficiency. Another important factor is malabsorption. Certain types of diseases or surgical procedures may result in decrease in the iron supply, gastrectomy, celiac disease اللي هي the GIT disorders. Poor diet. Usually, poor diet is a contributing factor. Rarely it is a major factor. For example, adolescents, usually they are nagging and they sort of tend to become picky in their food intake. So the decrease in the supply in the diet plus the increase in the demand due to the rapid growth and adolescence may contribute with each other to bring iron deficiency anemia. شو وقت يكون عندي poor diet a major factor؟ بأن يكون عندي infants and young children. طبعا هنا انه السبلاي هذول يعني حيكونوا مجبرين اذا كمية الحليب اللي ياخذها هي قليلة اكيد راح يكون عنده the major cause for iron deficiency will be poor diet. When iron supply to the body is reduced, iron deficiency anemia will pass into stages. The first stage will be the stores of iron are going to be depleted. راح المخازن مال الحديد داخل جسم الإنسان كلها تصفر. The iron stores in the form of ferritin and hemosiderin are depleted, and this happens first. هاي طبعا بالبداية تصير before the signs and symptoms and the laboratory features of anemia develop. After this stage of depletion of iron stores, I will have iron deficient erythropoiesis. Here the bone marrow will show the features of iron deficiency. راح نشوف انه الارثروبويسيس بالبون راح يبدي يصير ب disordered و shape مال red blood cells راح يتأثر. But still لحد الآن the hemoglobin and the red blood cells are still normal. The last stage اللي هي iron deficiency anemia stage, here the full picture, hemoglobin will reduce, the red blood cell count will reduce, the red blood cell indices, as we said, all are reduced, and the patient has all the clinical finding of iron deficiency anemia. Now, what about the laboratory finding of iron deficiency anemia? First of all, we have to do a complete blood picture. It will show that all the red blood cell indices, the MCV, MCH, MCHC are reduced. Hemoglobin definitely it's reduced as it's anemia. If we did a blood film for the patient, it will show the shape of the cells. They are small in size, microcytic. They are pale, hypochromic, with variation in size and shape اللي نسميه anisopoikilocytosis. طبعا اشكال الخلايا راح يكون مختلف حتى احجامها يكون عندنا بيها variation. عندنا target cells تطلع, some pencil shaped cells تطلع. الريتك كاونت الناس تتوقعون؟ اتوقع يكون عندي لو لانه اني نخاع العظم حتى لو اني ازيد الارثروبويتين هو اصلا عنده مشكله ما يقدر يطلع لانه ما عنده supply of iron. واحنا قلنا one of the major regulators of erythropoiesis is the presence of the building materials or the major requirements for the production of red blood cells اللي هي folic acids وال B12 والiron. So I expect the retic count to be low. That indicates a decrease in the bone marrow production of red blood cells. The platelet count is often slightly, moderately increased, especially when there is accompanied bleeding or hemorrhage. This is the normal morphology of red blood cells in the blood film. شوف السيلز تقريبا تكون حجمها حجم النيوكليوس مالت الليمفوسايت على مود نقارنها for the size. كمية السنترال بيلر تقريبا ثلث الريد بلاد cells. The cells تقريبا identical in their size and are identical in their shape. This is the normal appearance. Now, in iron deficiency anemia, we'll see the cells become paler. السنترال بيلر المفروض أني ياخذ ثلث الخلية لا أتوسع وبلع الخلية كلها. بعد شنو عندي؟ The cells become very small in size compared to the normal. نشوف إنه عندي variation in the size of the red blood cells and the shape of the red blood cells نسميه anisopoikilocytosis. طلعت لنا cells تشبه البنسل shape cells طويلة طولانية. And sometimes we even see target cells in iron deficiency anemia. So we get smaller, paler cells. Bone marrow, if we did a bone marrow, usually يعني أكيد we don't need a bone marrow examination to prove the diagnosis of iron deficiency anemia. But if it is done for another reasons, إيش راح يطلع عندنا بالiron deficiency anemia? It will show completely absent iron from the stores. in the macrophages and also from the developing erythroblast. يعني ما أقدر أشوف الحديد لا بالstored compartment بالمacrophages ولا أقدر أشوفه بالdeveloping erythroblast. If I do serum iron and TIBC, or the total iron binding capacity, it will show typically low iron and high TIBC. TIBC يعني شو نقصد بها total iron binding capacity? It's an estimation of the amount or the size of transferrin that's capable of binding to iron. It's an estimation of the amount or the size over transferrin اللي هو الكارير بروتين that is capable اللي ممكن انه ترتبط بالحديد. اذا بما انه انا عندي deficiency شو اتوقع هاي السايتس كلها شو حتكون فارغة capable of binding more and more iron. فاذا الايرون راح يكون عندي reduce والtotal iron binding capacity حتكون عندي عالية. This will help in differentiating it from anemia of chronic other forms of microcytic anemia. بعد شو يطلع عندي the percentage saturation of transferrin يعني كمية الحديد المنقول شقد مشبع الترانسفيرين بالحديد percentage saturation of transferrin will be low. To confirm further we do serum ferritin اللي هو هذا essential for evaluating the iron stores. أنا أقيس وإحنا قلنا الأيرون ينخزن يا أما ferritin يا أما هيموسيدرين. إذا أقيس السيرم ferritin راح ألقاه low. بس لازم نخلي ببالنا نقطة جدا مهمة إنه الفرتين is an acute phase protein. شنو يعني acute phase protein؟ أكون مجموعة من البروتينز اللي تزيد when you have inflammatory status regardless إنه يعني هذا الفرتين هو عندي يعني أكو iron deficiency or not. One of them is ferritin. It's an acute phase protein. Whenever we have inflammation or disease, it will increase. فراح يطلع الليفل مالته يجوز normal بينما بالحقيقة we have iron deficiency anemia. We have to do also investigation which is very important. مو بس أنا يهمني إنه أشخص إنه this patient is having iron deficiency anemia. I should look for the cause of iron deficiency anemia. Most of the time, patients are suffering from blood loss from the GIT and will point to important diseases, for example, peptic ulcer bleeding, CA in the colon, CA in the stomach. So we have to investigate for the cause of iron, especially if we are investigating a patient ويكون adult و male وعنده iron deficiency anemia. لازم واحد يعرف شنو الكوز مالتها. So we do occult blood in the stool for chronic bleeding peptic ulcer. We do duodenal biopsy if we suspect celiac disease. Any other screening test for any defect in the coagulation, probably he has a bleeding tendency or elsewhere. And then we have to search for the cause of iron deficiency. بالفيميل لازم نسوي لها ultrasound. لازم أعرف إنه هاي المريضة أخاف عندها فد cause for uterine bleeding. Now we come to another type of anemia that's also sometimes hypochromic, which is anemia of chronic disorders. This is also a very common type of anemia. Occur in patients who have inflammatory conditions, malignant diseases, autoimmune diseases, patients with SLE, patients with rheumatoid arthritis. They usually have this type of anemia that we call anemia of chronic disorders. شنو الفيتشرز of this anemia? This anemia is either normochromic normocytic يعني تكون الانdices مالتي بيها within the normal limit يعني ال MCV وال MCH وال MCHC تكون within the normal limits, or it can be hypochromic microcytic anemia where the red blood cell indices are reduced. بس عادة تكون ال decline or decrease in the indices less than that of iron deficiency. يعني إذا أنا بالiron deficiency على سبيل المثال ال MCV مالتي توصل لل60, بالانيميا of chronic disorders usually it is in the 70. احنا قلنا النورمال ليميت مالتنا هو حيكون 80 فيمتوليتر. الفيتشر الثانية of anemia of chronic disease is that it is a mild type of anemia, non-progressive anemia. Hemoglobin rarely falls to less than 9 gram per deciliter. عادة ما يتجاوز يقل عن 9. The severity depends on what? On the underlying disease. The severity depends on the underlying disease. شلون راح أميزها عن الiron deficiency anemia؟ أول شيء الأيرون والتي اي بي سي والترانسفيرين ساتوريشن they are helpful. هنا راح نلقى الأيرون والتي اي بي سي are reduced both. تذكرون احنا قلنا الأيرون reduced والتي اي بي سي increased in iron deficiency anemia. هنا لا, iron and TIBC are both are reduced. The percentage of saturation of transferrin is normal. أجي أقيس الفيرتين راح يكون increased or normal because it has an inflammatory states. وإذا سويت له bone marrow examination, the picture is very characteristic. It will show the presence of iron inside the stores, but it is not present in the developing erythroblast. يعني موجود بالستورز الحديد بس not in the developing in the erythroblast. What's the pathogenesis? Many different factors contribute to anemia of chronic disease. أهم factor إنه when I'm having inflammatory states or malignancy, this will cause production of many cytokines like tumor necrosis factors, interleukins. They will affect erythropoiesis. Plus, those cytokines and inflammatory states will result in increase in the amount of hepcidin. واحنا قلنا الهبسيدين من يزيد شو راح يأثر؟ يقلل كمية الفيروبروتين، يقلل كمية الايرون that's being released from the macrophages and the iron that's being absorbed from the GIT. إذن cytokines, the high hepcidin, the reduction in the lifespan, the inadequate erythropoietin response to anemia, all these are contributing factors for what? To the state of iron capture أو انحباس الحديد داخل الماكروفاجز with the defect in the release of iron from the macrophages to the plasma. إذن هو الحديد موجود بس شنو عندي صعوبة في نقله من المخازن إلى البلازما على مود يروح للنخاع to produce new red blood cells. ليش هاي الصعوبة عندي؟ Because I'm having effect of different cytokines like the TNF, the interleukins, the hepcidin. They all cause defect in this release of iron from the macrophages. وبعد عندنا other contributing factors اللي هي reduction in the lifespan of the red blood cells and inadequate erythropoietin response to anemia. Other causes of anemia of chronic disorders include chronic inflammatory states مثل ما قلنا rheumatoid arthritis, autoimmune diseases, chronic infections like TB, tuberculosis, bacterial endocarditis. All these can lead to anemia of chronic disorders. Malignant conditions like carcinoma, lymphoma anywhere in the body also can lead to anemia of chronic disease. So anemia is corrected by treatment of the underlying cause, and it will not respond to iron therapy. And there is no point of giving iron to those patients. They have iron but they cannot get يعني يستفادون من عنده، ما ممكن يستفادون من عنده. Other causes of hypochromic microcytic anemia راح يعني نمر عليها على السريع ما ندخل بالديتيلز. الثلاسيميا راح تاخذوها بمحاضرة منفصلة. The lead poisoning and sideroblastic anemia. Both these conditions we have a defect. احنا الايرون هو عبارة عن الحديد العفوي هيموغلوبين هو عبارة عن heme and globin chain. In lead poisoning and sideroblastic anemia we have a defect in heme synthesis. البورتوبورفارين ring اللي يكون عندي السنتر مالته بحديد الرينج نفسه البورتوبورفارين ring or the heme is defected in lead poisoning and in sideroblastic anemia. So this will result in reduction in the amount of hemoglobin with a hypochromic microcytic anemia. Thank you.